let me start by saying thank you to the organizers of this meeting and the session for inviting me. And to quickly set the ball rolling by no financial disclosures. And ART as an art was first described, I believe, by Tama et al. In 2016 in the landmark publication in the JAMA, in which he and Gawal noted impressive results, both structurally and functionally, after they successfully transplanted into a refractory macular hole an extramacular retinal piece of tissue. At the ASRS meeting in 2018, a case series was presented looking at the structure and the function of neurosensory retinal transplantation. It was an international multi-center experience of about 49 eyes. And in that particular presentation, Gawal, who was from Duke, looked at the structure, while Kazuki from Yokohama looked at the function. I'll quickly note that one of the members of this group, Barbara, is present in the room, and she may have something to say about this.
Wow.
So we presented 4 eyes of 4 patients of our own experience. The very first patient we had, who had an ART, post-operatively lost the graft, and so this was a bad experience, and for quite some time we decided not to do any. But following the presentation during the ASRS, we decided to do this procedure again, and the current technique we employed is as shown on the video. So typically, these are post-vitrectomized eyes, so we fill the eye with perfluorocarbon, we laser demarcate the area we hope to harvest. It could be superior, inferior, or nasal, and we excise a piece of tissue from the demarcated area, and under PFCL guidance, this excised piece of tissue is slid into the macular hole. It is teased open and spread over the entire macular hole, as is shown. The PFCL is topped up to the level that we deem adequate, and the PFCL is left for 5 days. And after these 5 days, we actually noticed that there's enough adherence to perform either an air exchange or a fluid or a gas exchange. In fact, in all the cases that I described, 3 of them had an air exchange only. Only the last patient had a gas exchange for some reasons which I'll discuss later on. So this was the video I've just shown you, the video of this first patient, the case 1, who was a 60-year-old female with a macular hole. And she had actually undergone macular hole surgery. I had performed the surgery, did a BBG assisted ILM peel surgery about 4 years back. And after the presentation by Tama and his group, I felt it was time to call her back. So her vision was 636. And then we performed ART just as I showed on the video. And I was quite impressed with the outcome. The outcome actually looked much better than I had thought it would be. And the vision actually improved, which surprised me because this was after 4 years of a reopened hole. And we can see the structural outcome on the OCTs shown, and also we see the superior area of harvest, which is very well scarred, just with air alone. So case 2 was a 44-year-old male, an only eye, and he had lost a fellow eye from glaucoma, from uveitic glaucoma. And when he presented to us, he already had a retinal detachment with a macular hole and multiple retinal bricks with PVR. So we performed the VT with silicone oil in 2017, and post-operatively, his vision was 636, but with a persistent macular hole. So we decided to perform an ART. And the surgery was done not too long ago, and we could see that the piece of tissue successfully was retained within the eye, within the macular hole, but his vision remained, Snelling acuity remained unchanged. However, he admitted that he had some benefit from the surgery. The area, he kept complaining before the surgery that there was an area of scotoma in front of his vision, and this area of scotoma shortly after the surgery had disappeared. So this was impressive. I thought this was impressive. So we went on to the 3rd case, and the 3rd case was a patient who had had surgery 4 years ago for retinal detachment. And this patient, unknown to him, had silicone oil in the eye, and when he presented to us, he had silicone oil in his eye. You can see the bubbles of silicone oil both on the retina and inside the macular hole. So his vision was 636, and we decided to go remove the silicone oil. And while silicone oil was being removed, we decided to perform an ART as well. And in this case, because I felt that the alignment, I was looking for how to improve on the alignment, I was a bit shy on the excision of the piece of retina. You can see that because of that, I didn't get quite enough tissue as I wanted. So one of the challenges that has to be discussed is how to make sure you get the exact piece of tissue so that the alignment is the way you would want it to be. His vision remains 636. He's just had 1 month follow-up. And this is the 4th patient who had an inverted ILM peel surgery for a stage 4 macular hole. And post-operatively, her vision deteriorated. Vision pre-op was 624, and post-op was 636, and the hole had reopened. So we decided to perform this. And what I noticed is that usually we do the OCT in first day post-op when there's still perfluorocarbon in the eye. And she had this amorphous piece of tissue, which actually was retinal tissue. And by the time we did the air exchange, you could see that there was beginning to be some form of presence of retinal tissue. However, I was not satisfied with the type of alignment that was there. The alignment was less than what I expected it to be. And this is also consistent with what has been presented, what was presented by Gewal during the ASRS meeting, during which first day post-op, you'll see some form of amorphous tissue, and then with time, you begin to see alignments even up to month 2. So from the collaborative study, I felt that our functional results were kind of similar, but functionally, we looked at those patients. Only one of them had a Snelling visual acuity improvement. 3 of them actually had same vision, but they actually did say, 3 of these patients did confess or did subjectively say that there was benefit from the surgery. None of these patients, importantly, lost vision. They were pleased with the subjective improvement and absence of scotoma. Only patient 4 still complained that she still had some form of distortion in her vision. And we noticed that from the slides on the OCT that the alignment was less than what we wanted to be, though it was just 1 month. We were waiting to see the 3 months and know whether the alignment will be better. So the collaborative study actually did note that about equal numbers of patients, 21 eyes, 43%, and about 40% of patients had an improvement in their vision, and another 20 eyes had an unchanged vision. So equal numbers of patients who had unchanged vision and those who gained vision. But they also noticed a clinical significant improvement in the vision of these patients who were seen. And the response to light following microperimetry was quite good in 10 eyes of 14. So the questions that remain to be answered include this. Is this a beneficial technique? And that makes us think, what should be the indications actually if this is a beneficial technique? And how should we really be taking care of or managing our recurrent macular holes? And that speaks to what are the expectations. What do we expect to tell the patients, both in terms of anatomy and function? And finally, is it a safe and effective procedure? And before we go ahead to answer these questions and our thoughts, I want to quickly share this experience with you. And this is the experience of the very first patient who had a failed ILM flap technique by me. Prior to this patient, all my ILM flap techniques had always gone very well. So this patient, very enlightened lady, a myope, very high myope, and she had the first ILM flap, and to my surprise, the hole did not close at all. And then I took her back to the theater, and yet still performed a repeat ILM flap, and still the hole did not close. This hole actually looked like this. And so I sent her to a colleague who at this point, I felt she didn't have confidence in me anymore. So I sent her off to a colleague of mine, and the hole looked just like that. It was a flat, open kind of, and she came back to me. She still used to complain about the scotoma, and she kept asking, "Doctor, when will this scotoma go away?" And I watched her for about a year, and this is how she looked the last time she came to the clinic. So the point is that the natural history of some of these patients actually makes them, once they've had surgery, to get worse. So it seems that if these patients are left without any surgery after they failed, they may deteriorate, and her vision actually did deteriorate. So we have to consider whether we want to see patients like that or patients like this one. So in conclusion, we described surgical tips for ART. Our limited experience appears to agree with the anatomical reports from a larger series. The learning curve appears reasonable for every vitreoretinal surgeon. And in fact, for me, I think that the learning curve here, this was my very first patient, and that you saw the video, the very first patient after a failed one. And the learning curve here actually seems to be better than it took me to learn to do a proper ILM peel. So the learning curve in ILM peel actually may be more difficult than doing an ART. There are questions regarding the functionality of the grafted tissue. The Snelling visual acuity may not be the best parameter to study if we're going to be looking at function. Maybe microperimetry may be the way to go. The indication for this technique needs to be better defined, and limitations, obviously, from this are the small sample size and the very short follow-up. We hope that as more and more vitreoretinal surgeons begin to participate in this, practice this surgery, we'll have better outcomes. Thank you very much.